Good morning, friends, and thanks, Dr. Harsh, for having given me this opportunity. What he said, bit every bit of your money wisely. I would go to the extent and say that whatsoever you have spent, recover aggressively. And then, if the patient has a normal disc and a normal visual field, then label that patient as a glaucoma and recover the money aggressively. Is it a wise thing? Obviously, as a good practitioner and an ophthalmologist, you would say no, and that is what I want you to say no, and no very loudly. That is the case who has a very healthy, normal looking optic nerve. You can see that the disc is following all the parameters which does not fit into the glaucoma. Rule is wisely followed with a normal visual field. But the only thing is that the patient has a higher intraocular pressure. You define normal intraocular pressure as a 10 to 22 millimeter of mercury. So probably the patient might be having higher intraocular pressure than the normal. If you have this scenario, then what to do? Obviously, first thing should come in your mind that whether you have recorded this intraocular pressure normally. If you record the intraocular pressure with the Goldman applanation tonometer, and if you are pressing the globe a bit, then obviously the pressure recorded would be on the higher side. If you are recording the intraocular pressure by the NCT, and once the gush of the air goes inside the eye and patient blinks, then you record the intraocular pressure erroneously on the higher side. Similarly, the case is true even with the Schiot's tonometer, you record erroneously high intraocular pressure. A very good history taking is very important because many of your patients might be on a systemic steroid. They might be having some skin problem and they might be putting some ointment which might be containing steroid, and if you put the patients with the leading question, then the patient may confess and say that yes, he is putting some skin ointment, or the patient might be having some bronchial asthma and might be taking the Rotacap or any other inhaler which might be containing steroid in the microdose. So you have to be very, very careful about that. The patient might be on the alternative therapy, and believe me that many of these alternative therapy may contain some steroid. So we have to be very, very careful about that. The gonioscopy, as Dr. Harsh has pointed out, should be the integral part of your examination, and you must do in each and every patient who has a high intraocular pressure. One thing you may find on the slit lamp that the AC is deep. The Von Herrichs is grade 3, grade 4, but still when you put the gonioscope, you might find that the patient is an angle closer suspect. And that is not only the case. If you put the gonioscope, then you may find that the patient have had the angle recession. He might not remember. You might not have asked the patient about the history of trauma, and probably the angle recession might have caused the intraocular pressure, raised intraocular pressure at 15-20 years later. So you have to be very, very careful about that, and you must perform the gonioscopy in each and every patient having a high intraocular pressure. The thorough examination of the optic disc and the RNFL is very essential. You might pick up some splinter defect or a small minute disc hemorrhage which you might miss otherwise. The diurnal fluctuation, you must remember one thing, the high CCT, some of the patient, particularly the patient who has a microcornea or a coloboma, they have a very high CCT. It goes more than 600 micron, and obviously this patient would be having erroneously high intraocular pressure. And if you suspect the patient may have a glaucoma and the SAP is normal, then don't hesitate to go for the higher test like the swab, or may do the OCT and the GDX. What could be the differential diagnosis of a patient who has a high intraocular pressure, normal disc and the normal standard automated perimetry? Then it could be IOP related issues that, as I have discussed you, the patient may have angle closure, intermittent angle closure or an angle closure suspect, ocular hypertension, the pre-perimetric glaucoma, patient might have a attack of uveitis, the pigmentary dispersion syndrome, but with the normal disc and the perimetry, the pseudo-exfoliation, the angle recession, and this steroid responder. The steroid responder, Dr. Manish is going to talk in detail. IOP-related issues, I have already discussed all these issues, but you have to be very, very careful while you record the intraocular pressure. And remember one more thing, whenever you do a nice Goldman applanation tonometry, then also I found that always the first reading is slightly higher than the second reading. So whenever I do the applanation tonometry, I always take 2 or 3 readings, and I always found that the second or the third reading is 1 or 2 millimeter lower than the first reading. So that is very important and critical. Let us try to understand a bit of the ocular hypertension, because the ocular hypertension is one of the conditions where the patient has a high risk of development of the primary open-angle glaucoma. If these patients are not treated, then probably 10% of your ocular hypertensive may convert into primary open-angle glaucoma on 5 to 6 years of follow-up. That is what the ocular hypertensive study, the OATS study, has taught us. So whether you have to treat all the ocular hypertensive, because the conversion into glaucoma over the 5 to 7 year of follow-up is significantly high, but on the other hand, the 90% of your patient would not convert into the glaucoma. So probably we have to find out the important risk factor which might lead to conversion of the ocular hypertensive into glaucoma. So what could be these important risk factor? That is all the post-hoc analysis of the OATS study has taught us. The older age per decade is one of the important risk factor for the conversion of ocular hypertension into primary open-angle glaucoma. The higher vertical CD ratio and the thinner corneal thickness, that is an important thing which the OATS study has taught us about the correlationship of the thick and the thin cornea with the open-angle glaucoma and the measurement of the intraocular pressure. The family history of glaucoma, the patient who has a strong family history of glaucoma are probably 20 times more prone for the development of glaucoma as compared to the normal individual. And the myopia. Remember one thing, the thinner cornea and the higher presentation of the IOP is more related to development of the primary open-angle glaucoma over a period of time as compared to the thicker cornea and low intraocular pressure, at the relatively low intraocular pressure at the presentation. So who needs the treatment? In my opinion, every patient who has an intraocular pressure more than 30 millimeter of mercury, though they may have a normal disc and the perimetry, probably we must lower down the intraocular pressure. The intraocular pressure more than 25 millimeter of mercury, with the risk factor, probably you may consider treating them. Intraocular pressure more than 21 millimeter of mercury with a vein occlusion in one eye or in both the eyes should be considered for the treatment. The second important condition is the angle closure suspect. You put the gonioscope and you will find that the patient has a narrow angle. And these patients who are repeatedly having a attack of intermittent angle closure, you can find the blotchy pigmentation or scattered 1 or 2 synechia. These patients must undergo the prophylactic peripheral iridotomy. The pre-perimetric glaucoma. It is very common. If you are not doing a thorough disc and the RNFL examination without dilatation, then you may miss it out. You just dilate every patient who need a dilatation and a high intraocular pressure and do a careful 90 diopter disc and RNFL evaluation, and you may find this kind of a small hemorrhage and the splinter defect over the RNFL. So this is a pre-perimetric glaucoma because you have done the perimetry and it is normal, and the disc and the RNFL does show the changes related to the glaucoma. And why the pre-perimetric glaucoma? Because until and unless the 40% of the ganglion cells are died, you do not see any changes on the standard automated perimetry that all of us are fully aware. But if you do the functional test in these kind of a patient, then probably you may find small changes over the RNFL defect and just see that over a period of time at the same location these RNFL defect has progressed. So what more evidence you need? Obviously this patient need a treatment and you have to lower down the intraocular pressure by approximately 20 to 25% from the baseline. And how to do the follow-up? Just like a primary open angle glaucoma patients. Uveitis, the patient might have a frequent attack of the uveitis. They may have a normal disc and the normal field. You have to be very, very careful to see with high magnification whether the patient has a cells and flare and the keratic precipitate, and try to rule out the PS syndrome or the Fuchs heterochromic stylitis. And if they have these, then treat them accordingly. Look at the angle recession. The patient may not have developed the feature of the angle recession glaucoma. Look at this Krukenberg spindle, particularly in the moderate to high myopia, and if the patient has the normal disc and the field, then also consider it as a high risk of development of the glaucoma and follow the patients accordingly. Steroid responder, Dr. Manish is going to talk about that. So any patients having a high intraocular pressure with the normal disc and the normal visual field, you have to do a good thorough follow-up regularly throughout his life. Thank you very much for your patience hearing.